Thank you. Thank you for the opportunity to speak to you about mental health and psychosocial support in humanitarian emergency as part of this webinar series. My name is Ragnhild Dybdahl, and I'm an Associate Professor of Global Mental Health at University of Bergen and also a Senior Advisor at the Norwegian Institute of Public Health. I worked in development cooperation and humanitarian assistance for nearly 30 years, different capacities, and I'm very pleased to be invited to share some of my experiences and thoughts with you. I'm going to speak particularly on the context of implementing and planning mental health and psychosocial interventions. So not the interventions per se or the techniques, but the setting in which to do them. What type of principles and guidelines exist so that we put our knowledge and our work to as much good as possible. The background for this is that mental health and psychosocial support increasingly is part of development and humanitarian assistance. One reason for this is that we now know that people who experience complex emergencies, potentially traumatizing events, conflicts and disasters have higher prevalence of mental health problems than other people. New WHO estimates just a couple of years ago found that about 22% of people who have experienced conflict either can be diagnosed or identified as having mental health conditions, especially PTSD, depression, and anxiety. This is probably because those are the conditions that are mostly studied. There are a few studies on other conditions as well, including psychosis and bipolar disorders, but many fewer. What is standing in what we do know is that this is high prevalence. However, it does mean that the majority of people do not develop psychopathology, do not develop long-term or chronic mental health conditions. However, 22% is a high number. In addition, we have to consider that many people also had problems before the crisis, before the conflict, and these problems are not likely to go away, and so that also needs to be taken into account. And thirdly, not all the problems are caused by the crisis. Some are, and those are the ones we tend to address when we talk about mental health and psychosocial interventions during and after crises, but others were pre-existing or were perhaps even caused by aid or by our efforts to help. And one reason why we have developed over the years principles for implementing interventions is to avoid this type of harm. Behind these interventions, behind the principles, lies some fundamental knowledge on mental health. In the recent years, especially since the launch of global mental health articles from the Lancet that started in 2007, but recently, and especially since then, there's been a shift in how we view mental health in a global perspective. One of these shifts include a realization of what is called the treatment gap, meaning that very few people who need mental health help or support actually receive such help. In low and middle income countries, the number of people who need mental health support and treatment and who actually receive it seems to be about 10 to 20%. So 80% do not receive help. This is called the treatment gap, and it's something to take into consideration. Another aspect that has really changed the way one views mental health is the importance attached to lived experience. The perspective of people who have had or have mental health conditions or have family members with mental health conditions. And their experience, their opinion, their views are central in planning, in implementing, and in evaluating any intervention. Another aspect that has changed the way we look on mental health is to see it as a spectrum. It's not sick or well, it is a whole spectrum from promotion of good health, prevention of bad health, to treatment and rehabilitation. So you've got this spectrum, and what you do, how you plan your interventions, depend on where on this spectrum you want to intervene. Also, the acknowledgement or knowledge that we now have of the importance of social and economic conditions for mental health really influences how we look on what we can do. So social and economic determinants are very important for mental health, both in terms of conditions that can promote mental health or can hinder mental health, but also treatment. So being poor or worrying about money or being lonely are very important factors when it comes to mental health. This is what's related to a long-term discussion in mental health work in disasters about war trauma versus life stresses. Life stresses can be such thing as not having a home, or worrying about money, or being alone, not knowing the language. And it's repeatedly found that life stresses or the living conditions explain a lot of the variance in mental health. So even if our prime focus is on trauma, we need to consider the context in which people live and their potential protective factors as well as stressful factors in their lives. The report here is a very good one from World Health Organization on social determinants on mental health. Finally, in changing the way we view mental health is the realization that we cannot continue to do things the way we have always done. Educating more psychologists, more psychiatrists, more specialists will not solve the treatment gap. Instead, innovative approaches where the support and the treatment is being provided closer to where people lead their lives, where they live, by people with less specialized skills, it seems to be a very fruitful solution. This means involving the community and teaching self-help skills and what is called task shifting or task sharing, meaning that specialists will not be the main providers, although they still will play a very important role. One of the flagship programs for task shifting is the MHGAP by WHO, which exists in many, many languages. Now, the main topic that I want to share with you is about principles and guidelines for mental health support in emergencies and after emergencies. Because one has found over the years that not all interventions do good, these principles have been developed based on learning from previous mistakes. And a number of such guidelines exist, and here I mention some, and I will especially be referring to the guidelines by the Interagency Standing Committee. These were first launched in 2007, but have been revised several times. There are also others that I encourage you to look up. Here are examples of such guidelines that you may find useful. The Interagency Standing Committee Guidelines on Mental Health and Psychosocial Support in Emergency Settings is a very comprehensive but also very practical, and has been used in conflict settings and emergencies all over the world. Basic principles from these guidelines involve building on human rights and justice. So they all emphasize a human rights perspective, which means that some people will have duties and others will have be duty bearers and right holders. It means that the way that help is provided is guided by this rights perspective. Another basic principle that cuts across all the guidelines I've been able to find is the importance of participation, that people who have been affected by war, people who have escaped or are refugees, people who have family members with mental health conditions in these circumstances are listened to, that they have a say, that their opinion is taken seriously, and that they are informed and active participants in anything that concerns them. And the principle of do no harm is fundamental to all health workers, and no less in humanitarian emergencies. Even though an intervention per se can be has been found to be effective, it may still do harm in an emergency setting. For example, if a mental health intervention is organized in a way that people who would normally work in the hospital no longer work in the hospital, but actually undermine the local system by working for a non-governmental organization or in a different organization. So if it's not coordinated, then it could do harm to the overall system. Or if the help is provided to one group, but not another group, it could create hostility, which in the longer run would do harm to the community. Building on existing resources and capacities is a fundamental principle. You build on what there is. You don't arrive with what is the best solution. You build on what the needs are and what the resources are. As I think will be pointed out in several of these lectures, interventions should be organized so that they promote coping, so that they promote resilience, that we do not have a deficit perspective necessarily, that you do not look only for the weaknesses and the needs and provide treatment, but that there are ways to promote active coping. As I started up saying, most people will not develop permanent psychopathology or long-term psychopathology, meaning there is a lot of resilience in people and in communities, and we want to strengthen this. Interventions should, ideally, to as large an extent as possible, be community-based and to be provided as close to where people live their lives as possible. And they should be carried out in a way and organized in a way that they're culturally relevant and acceptable to people. Social support is a fundamental principle. So mobilizing networks, social networks, is a basic principle for psychosocial support. The last 3 bullet points here I will speak about more or less for the rest of the lecture. The first one is integrated services, that the service or the support is seen as part of a whole system of support, so that we try to avoid standalone interventions, say trauma interventions that is a one-off, or training that is 3 days and nothing more. It should be part of a system of care. And in doing so, the Interagency Standing Committee guidelines, along with many others, recommend using a multiple level system or multiple levels of needs. And this is illustrated here in this Interagency Standing Committee intervention pyramid. This pyramid is divided into the blue here, which is the basic services, the approaches of psychosocial support that goes for everyone. Everybody needs safety, security. And the way that these basic services are provided can promote mental health and resilience, or they can hinder and threaten mental health. So, for example, education is a basic right for children, and if education is done in a way that promotes mental health, in a way that is respectful to children, where children are not beaten, where they're not punished if they cannot concentrate, that the teachers understand the stress that children may be under, then those basic services can promote mental health and actually prevent long-term problems. This will be enough for many people, or for most people. Basic services that are done in a good way, integrated into other services, whether it's rights, whether it's legal services, food, shelter, water, income-generating activities, these will be enough for most people, but not for all. Some people may need different support or extra support, for example, family strengthening or in preventive interventions. I will mention a few examples of those as well. For other people, even that is not enough. For people who have been identified as being traumatized, for example, who have nightmares, lack of concentration problems, depression, etc., then focused help may be needed. This can often be provided by non-specialists, maybe in groups. It does not mean medication necessarily, but it can be very effective and very important. And in fact, this is the area where most of the research seems to be focused when it comes to these areas. Finally, some people will need specialized care, medication, maybe hospitalization, psychologists, psychiatrists, therapy, and it's very important that these needs are also met. People with severe mental health problems are especially vulnerable in crisis situations. Also, this pyramid means that there is a referral system. It means that if one level is not enough, then there is another level to go to. So these actually depend on each other. For social workers and teachers and community workers to provide counseling or psychosocial support at the low level in the pyramid, they may need guidance, supervision, and support from specialists who are at the top of the pyramid. So there will always be enough work for those at the top of the pyramid. One intervention or approach that is increasingly recognized and used is what's called psychological first aid, which is basic psychological or psychosocial support in crisis situations. This guide exists in many languages, and there's a training manual to go with it and ready-made slides. And it consists of ways to promote coordination so that those who provide psychosocial support or other first responders actually can cooperate and coordinate and provide services that people can reach, that are free or available and accessible. Information is an important part of psychological first aid. For many people, a crisis situation will involve losing a lot of safety and security and receiving good information, even if the information is that we do not know. But to receive accurate information may be reassuring and at least create some sense of coherence and predictability. Psychosocial aid in this type of psychological first aid also includes meaningful activity, that doing things is good for people, dignity, friendliness, humanity. So to be met in a respectful way, in a friendly way, never a pushy way, is important. And also the importance of practical help. So practical help can be very important for mental health and to promote coping strategies. Then one example of such basic intervention at the basic level of the pyramid is to promote resilience and prevention through involving families or through strengthening networks. So this example here is from the largest refugee camp in the world, in Cox's Bazar, where people have organized ways to go around from house to house or to support people, to give information, to try to strengthen networks. It can also be religious rituals, it could be educational activities, it could be many other issues that make people help each other and strengthen social and economic factors. Information I already mentioned, so information to parents as well on how to support their children in extremely difficult circumstances have been found to be very important. Here are some very simple pieces of advice that have been developed very recently, just as examples of such basic care. For example, how can you take care of yourself as a parent so you can support your child? For example, when the stress is too much, take a moment for yourself. Maybe this seems obvious, but maybe it's not in an extremely stressful situation. Here's another way, another one of these cards. They also exist in many languages, of practical ways to help people cope. For example, by establishing routines in everyday life. For children, a system of what's called nurturing care is a basic service that can be done, or basic need and a basic right that can be done in a way that promotes mental health. This has to do with protection and health and nutrition and learning. And it's here to remind us that mental health is never the only issue for people in emergency settings. And even though our job may be mental health and psychosocial support, we should also take into consideration other domains and collaborate and coordinate. For children, parents and caregivers are extremely important. And if they're not there, either physically there or for other reasons not available to support and look after their children, children are at extreme risk. Therefore, there have been good tools developed to support parents. For example, this one called Thinking Healthy Program by WHO, which is part of the MHGAP that I mentioned, which deals with depression in mothers-to-be and in new mothers, and is provided by non-specialists in the community. This is another program that is been used for a number of years in emergencies, but also in non-emergencies, and it's called International Child Development Program. And this program can be used in communities and over time to support caregivers in stressful situations so that they can better care for their children, not by teaching them things they didn't know, but by strengthening what they already do and know, and building on the resources they already have. The more the targeted approaches, so higher up in the pyramid, there are a number of good manuals and strategies available. Here I've mentioned three. One is called Teaching Recovery Techniques, which is a trauma-focused program, very simple, can be provided by people who are not specialists at all, to help children cope with trauma symptoms, such as lack of concentration or nightmares. And it's also in many different languages, and it's provided by Children of War Foundation. In the middle here you have a manual called Problem Management Plus, which can be provided in individuals or for groups, and has been found to be very effective, and again, not provided by specialists. And finally, Mental Health and Gender-Based Violence, which is a manual that you will also hear about in other parts of this series, which is similarly organized so that it can be provided in groups to women and others as well who've been victims to sexual violence. To bring these interventions to scale, to provide to many more people, it's important to try to integrate the services into primary health services, not to compete, not to exist, to create a competing system or a parallel system, but to integrate into the health services that exist when possible, and to make them community-based. To use non-specialists to provide services, to try to find one type of treatment or manual that can reach people in difficult situations, even though they don't have a diagnosis, and not look just for one treatment for each diagnosis, and to focus a lot more on skills and self-management. Here is another guide similar. It's called Doing What Matters in Times of Stress, which it provides stress management system support and ways to do that. I mentioned the TRT, Teaching Recovery Techniques. Here's an article that you may want to read showing how it works and the evidence for it. And a very recent report as well. Finally, the specialized interventions at the top of the pyramid. This is not the topic of this lecture, but they are necessary in order for the rest of the pyramid to function. And as you will maybe know already, and you will learn, many of these tools that I have mentioned here and others exist in a number of languages, and during the Ukraine crisis, many of these have been translated into Ukrainian, Russian, and many other languages, and here you can see the different tools and what languages they exist in. And finally, I have gathered some references that I hope will be useful. Thank you very much.